Hello, everyone. My name is Tiffany Boynton. I'll be presenting a paper. It's about the Triton Hodge test, and it's about an improved protocol to improve it and enhance it for detection of NDMs and other carbapenemase producing organisms. My outline is where I'll start, and first I'll be talking about why this is important to me. I will be talking about hospital-acquired infections. We'll go through a little bit of the understanding of gram-negative and gram-positive infections. We'll talk about gram staining procedures, the history of drug resistance. We'll go into the specific bacteria as well that the paper addresses, which is NDM, and then we'll be talking more about the actual paper at the very end. We'll try not to bore you guys too much. And it'll just be about the Triton Hodge test, which is the modification to the modified Hodge test. So, and then we'll also talk a little bit about the implications of false negative and false positives in the healthcare setting. Okay, so I'll first start off with why this is important to me. When I was a CNA, I actually, on one of my first days of working in the hospital, I came across a patient with an infected port. The port that this patient actually had was an internal jugular vein port. And it was like just sitting there exposed. There was no port there anymore. It was just a gaping hole. And I was so curious about this and why this had happened. And she explained to me that basically she had acquired an infection while in the hospital, and it left this hole in her neck. And she had been there being treated for something totally different. And because she had had a port put in her neck, that port got infected, and which left her with this horrible scar and needing to be healed. So it also made me very kind of paranoid, not paranoid, but just very cautious about hospital infections from that point on. And when I joined the military and became a medic, it just was natural to me to always keep my eyes open for signs of infection. And this is why this paper is so important to me, and all like sorts of issues with infection and safety. So this type of infected port can also happen in subcutaneous ports, PICC lines, catheters, and it can also happen like with vents, like where a person is being put on a breathing machine for a long period of time. I'll show you a picture right now of what I saw on that patient, something similar to what I saw. And if you guys are squeamish, just don't look at this next picture, and I'll go through it pretty quickly. So this is pretty much what I saw. It was just a hole there, and that double spot is just where you're threading it in to the area. So yeah, and it was just left unhealed and just open, and it was going to take a really long time for something like that to heal. So I'll go on to the next slide. So infections acquired in the hospital setting are considered to be nosocomial infections. And so some people call them HAIs, or you might even hear some people call hospital acquired infections or healthcare associated infections. So both of those are HAIs. So it's just something you're gonna learn about because it happens all the time. Even with people really being precautious, wearing PPE, gloves, all sorts of barrier protectants, even droplet precaution rooms and things like that. With patients, you still get nosocomial infections or hospital-acquired infections. Let's one. What are gram-negative and gram-positive bacteria? So I'm just gonna quickly go through this, but I'm gonna show you the picture while I kind of go through this slide. So gram-positive and gram-negative cells have like 2 layers. Gram-negative have 3 layers and gram-positive cells have 2 layers. The gram-positive tend to have outer thick peptidoglycan layer, and that makes up about 60 to 100% of its membrane. So that's where that red arrow is pointing. But as for gram-negative, they tend to have 2 thin peptidoglycan layers, and they make up about 5 to 10% of the cell membrane. The next one, the plasma membrane for the gram-positive is an inner membrane, and as for the gram-negative, it has 2 phospholipid layers. You can see where the arrows are. The procedure for gram staining, this is why the cell retains its colors, and it's because you go through this procedure. So first you add crystal violet dye, and it is placed on the bacterial smear slide for 1 minute. At this stage, both gram-positive and gram-negative cells will stain purple. Then you'll wash the slide and rinse it to remove excess dye. Then you'll have gram iodine, and it's placed on the bacterial smear slide for 1 minute. Iodine acts as a mordant or like a hardener, and it's a substance that helps to fix the dye to the thick peptidoglycan cell wall of the gram-positive bacteria. Then you rinse to remove excess iodine, and then you add alcohol as a decolorizer, which is used to rinse the slide. Due to the iodine acting as a mordant for the crystal violet in gram-positive bacteria, the gram-positives will remain purple even as they are being decolorized. Gram-negative bacteria will become colorless at this point. Then you wash, rinse, and remove the excess alcohol, and then you add saffron and dye to the slide for 1 minute. After this is done, you can visualize it under a microscope, and you should be able to see gram-positive bacteria as well as gram-negative bacteria. The gram-negative bacteria will stain more of a pink color, and then the gram-positive will stain more of a purple color. So gram staining is not the main method of diagnosis or identification of bacteria. It can be used to establish whether there are significant numbers of bacteria or if there are multiple types of bacteria. It's kind of like the fast way of seeing what you're dealing with, at least while you are waiting for like other lab methods to culture and grow and display results. So, because that can take time. So the problem that we run into is really just antibiotic resistance. There are very serious complications that plague medicine right now, and that is just that the medicines that we have aren't working the same anymore because those bacteria that we are using them on are being naturally selected for, and the ones that are resistant to the medicine survive and they thrive because there's not as much competition, because you've eliminated all the things that are not superbugs and you have what's left and they don't have to fight or compete with anything. So they're being naturally selected for. It's considered to be one of the preeminent public health concerns of this century. Scientific evidence supports the notion that pathogens have evolved and have the capacity of conferring genetic material to other species, creating these superbugs. A really important paper that came out was in the issue of Science Compass magazine in 2001. And it was talking about drug resistance and also other types of resistance that have grown over the years. It was called Humans as the World's Greatest Evolutionary Force, and it was by Stephen R. Palumbi. It was just talking about drug resistance, and it discussed the effects of medical advancements and the evolutionary mechanisms at play in bacterial antibiotic resistance. He analyzed herbicides as well, but one of the major parts of this paper was the drug resistance, the history of drug resistance. So he analyzed how our treatments have had to adapt quickly to be effective against the increasing resistance of the bacteria over time. They noticed it immediately that certain drugs weren't working anymore. So one of the most important tables, there were two very major tables. One of them was a little more simple, but this particular table, table 1, was one of the more standout tables of that paper. And it just basically talked about how throughout the history of these antibiotic discovery, antibiotics has been one of the most profound discoveries, penicillin and just its ability to kill off infection, because infection was what killed people historically before antibiotics. Even if it was simple things, when they were infected, people died. So the fact that antibiotics came around was profound, and they used it to help cure pretty much everything that was killing people. So and the death rate really dropped off when antibiotics came around. And the antibiotic is in the first portion of the table, as you can see, and it just shows the year that they deployed the antibiotic and then the resistance observed. The first one was the sulfonamides, and they're saying that the antibiotic really came out really big in the 1930s, and the resistance was already there by the 1940s that they could observe. Some other ones that stood out in this table were penicillin in 1943 and its resistance in 1946, which is only 3 years of pretty much active ability without it having any issues. But people who were most likely this was people who were consistently using it, were already having resistance issues to it immediately afterwards. Fortunately, scientists were on it. They were trying to discover more and new antibiotics that could help treat infections, but they quickly learned and saw a pattern, and over the years, they've had to continuously try to find new treatment. Methicillin in the 1960s was another notable one. It came out in 1960, and resistance was noticed in 1961. So for our paper, for the Triton modified Hodge test, to the Triton modified Hodge test paper, the main culprit or superbug in question was the NDM-1. NDM-1 is also known as New Delhi metallo-beta-lactamase. It is an enzyme that is produced by a specific strand of bacteria that have recently evolved. So whenever you see the ACE, that just means it's an enzyme. The last few letters of the word ACE means enzyme. And when they're talking about bacteria, they're talking about its ability to eat basically the antibiotic or destroy the antibiotic and not be affected by it. And if they produce that enzyme that is effective against the antibiotic, then the antibiotic is not considered a drug of treatment that you can use, and you'll have to go either up a level if there is, or you'll have to find an alternative treatment. Unfortunately, for this type of bacteria, as we'll discuss, it's a carbapenemase producing enzyme, and there is no antibiotic of treatment above that. So the significance of this enzyme is that it's active against the B-lactam ring. In addition, the bacteria have acquired NDM-1 and have also acquired the resistance factors, making them resistant to all commonly used antibiotics, which is what I got ahead of myself. NDM-1, although there are many types of beta-lactamases, the vast majority are effective against the older beta-lactam antibiotics, and NDM-1 is effective against the older beta-lactams and the carbapenems, which is the highest level, as I said. That's an antibiotic of last resort. Anytime you hear carbapenem, you're talking about that's as strong as you get, and you really don't want to use it unless you know that it's going to be effective, because it's going to wipe out pretty much all the good and bad bacteria in the patient's body. And whenever you do that, you're naturally selecting for anything that is resistant to that. So such that bacteria producing NDM-1 is virtually resistant to all antibiotics. NDM-1 has been found in 22 carbapenem resistant organisms. And so that the structure that you see below is what the carbapenem looks like, the chemical structure. The detection technique that has been historically used to detect carbapenemase producing enzymes in bacteria is called the modified Hodge test. It is a carbapenem inactivation assay, and it is just used to detect the assess the effectiveness of the antibiotic against gram-negative bacilli. NDM is a lipoprotein anchored to the outer membrane of gram-negative bacteria. I've actually tried to find this picture, and I've seen it one time, but I have not been successful in finding a picture of the actual lipoprotein or someone illustrating a lipoprotein that's considered like a carbapenemase producing lipoprotein on the outside of the bacteria. So sorry about that. This anchoring complex causes masking of carbapenemases, leading to a false negative during the Hodge test. So pretty much there's like basically a covering over the area that where the carbapenemase enzyme comes from. And so you can't see, or you can't detect using the modified Hodge test the production of the enzyme. So it kind of makes you think that the carbapenem antibiotic would work, but it actually doesn't. So that's what this this test is about. This modification is about. The timeline for MDM discovery: 2007, Swedish residents hospitalized in New Delhi, India. And that's where it was basically discovered, the bacteria. The public description for Interscience Conference of Antimicrobial Agents and Chemotherapy, it was presented there. They were given a description of it, and I'm going to skip the rest of them, but basically by 2010, it was already in the US and they were issuing their first warning. So it's very quick. It spread very quickly. this bacteria. So the modified Hodge test is a phenotypic screening test, and it's just basically an agar plate. And basically you're just attaching the antibiotic to it to see if the bacteria is resistant or not. The test was unsuccessful due to the false negatives and its inability to reveal the content of the membrane anchored lipoprotein on NDM. The Triton Hodge test is a modification to the modified Hodge test, and it improves the test, and it allows for the detection of NDM using a surfactant, which is just soap. Basically, it's a soap, it's a detergent that you're adding. A lot of people add it to different tests, and it just exposes the lipoprotein layer and allows disintegration of that layer. And so it exposes the enzyme, which shows the resistance of the bacteria to the antibiotic, the carbapenem antibiotic. So, sorry, yeah, the table. The cancer test it's a way to explain this a little better, the importance of false negatives and false positives and things like that, is to always talk about, I guess, cancer test results, because it just sticks in your mind better if you understand cancer test results. So when it relates to cancer, a person who actually has it's positive for having cancer and their cancer test results show positive, that's good. We want to know that they have it, and we want to have an accurate test that shows that they have it. That way we can treat them properly, effectively, quickly, and have good results or a better prognosis. Now the problem runs into you telling someone that they have cancer and they don't. That will be an actual negative test, but you're giving them positive results. And this happens actually often, and not just with cancer, but with lots of other things. And this costs lots of money. Just imagine starting treatment on someone who does not have cancer, who does not have what it is that you think that they have, and you're wasting all the healthcare money, all of the insurance money, and then you're wasting their time, and then you're also wasting effective treatment time for whatever they actually have. So one of the other really bad problems is when you give someone positive results when they actually are positive for cancer, but you gave them negative results, and that's deadly. That's something that could actually kill somebody, because you can't treat them. You've told them that they're okay, and so they've gone on and left, and now they actually are positive, and you've lost all this treatment time, things that you could have been doing to be more effective. And in this same way, this is why it's so important for the modified Hodge test and the Triton Hodge test, because if you think that a person could have effective treatment with a carbapenem, it is very important that you're right about that, because it's such a heavy, hard drug, and it is a drug of last resort. So you're going to be wiping out this patient's entire pretty much immune system and ability to fight back infection, because you're trying to take out this bug, but you could actually be naturally selecting for other bad things. And then also you could be ineffective in causing a loss in time of treatment, good treatment time, doing something else that could have been more effective, maybe something more natural, or because you really don't have any other antibiotic after a carbapenem. So if you find out that this is not working, this is not going to work on an agar plate, it's so much better, and it's a lot less money and time and effort rather than treating the patient and realizing it does not work. So I'm just going to quickly go over the actual test and explain to you what they did. So in interpreting the results of a modified Hodge test, you're basically just looking at the area of growth. So these are positive results because you can see this clover-like growth all around the area, around the zone, the disc diffusion zone. This is the disc, and then this is the diffusion. Oops, I'm messing up my. This is the diffusion zone, the area all the way out to where the dashes are. The clover-like indentation around the streak within the disc diffusion zone indicates growth. No growth around the streak within the streak of inoculum. So you have these streaks that are going out, and that's where the bacteria are. So no growth around the streak within the disc diffusion zone indicates a negative test. So I'm going to go to, and this would be a negative result right here. And the ones that have the growth, the curves right here, that just means that that's growth. So the next page. So in the results of the modified Hodge test, Triton Hodge test, section A, figure 1A shows negative, a false negative for NDM-1 membrane bound, however, positive for NDM-1 periplasmic and NDM-1 periplasmic. So basically it's a false negative here. So right, point at it, right here, this should be actually positive, but here it's negative on here. So we're gonna go to the next one. Figure 1B shows a positive for NDM-1 membrane bound and also positive for NDM-1 periplasmic. So these are the same bacteria, but it's showing you that this test actually works when you add the Triton, the surfactant to it. So as you can see, this same area that is the same one as over here, same bacteria, is showing it as positive. It just grew because they added the Triton to it and exposed the enzyme. Figure 2A shows positive results for VIM2 periplasmic and negative for NVIM2 periplasmic. Okay, right there, right here. And then the control was PMBLE. I'm not going to go into all of that. I probably says don't go that deep into it. So, all right. The last one shows positive results for VIM2 periplasmic and positive for NVIM2 periplasmic. It says, notice that PMBLE is still used as the control. Okay, so as a conclusion, the importance of proper detection of carbapenemase producing bacteria results and appropriate treatment of infection, it is pertinent because it's not just about the money, it's about the patient's health and overall long-term implications of what's going to happen to them. Because, you know, if you're not using the time effectively to treat them and you're wasting time doing things that aren't going to work, it can be just very devastating to the patient because they have to deal with those infected sites every day. So MHT is proven unreliable. The modified Hodge test is proven unreliable in the detection of NDM-1 producers. The Triton Hodge test has proven most reliable where NDM-1 membrane-bound lipoprotein class B is a concern. MHT, and that's something to be said there because the other tests showed that modified Hodge test was still very effective in other classes, but in the class B, it wasn't as effective. MHT media alone is incapable of solubilizing membrane-bound lipoprotein. False negative results became positive upon the addition of Triton X100. Triton X100 may also be useful in future studies of enterobacteriaceae, where MHT test was uninterpretable. So last but not least, with the addition of Triton X100, these researchers have discovered a test modification allowing NDM-1 detection and providing sensitivity of other carbapenemase producing gram-negative bacteria. The nature of these simple and inexpensive changes have a positive impact on laboratory diagnostics worldwide. And I'm quite sure that many of the patients would appreciate it as well. I don't know whatever happened to that patient who had the infected neck port, but I hope she's doing well, and I hope you all enjoyed this presentation. All right, thank you. Have a great day.